Good afternoon, everybody. So, from the Gynae 3, Unit 3, Department of Obstetrics and Gynecology, we present an interesting case of aplastic anemia with paroxysmal nocturnal hemoglobinemia. So, both the situations are uncommon, but when put together, are certainly rare. This woman had a roller coaster ride during her gravid pregnancy. So, to take you through her journey of her pregnancy is Dr. Gayatri, followed by Dr. Shubhi, our senior resident, who will allude on her review of literature and what we've understood to manage these two diseases in combination.
Good afternoon, everyone. So I am taking you through the case history of this patient. She was Mrs. X, a 26-year-old female patient, gravida 3, para 1, living 1, abortion 1, resident of Lucknow, Uttar Pradesh. She has presented to our casualty at 30 weeks gestation with complaints of petechiae, bleeding from gums, and mucosal ulcers since 2 days. She is a known case of aplastic anemia with PNH on immunosuppression since 2018, under regular follow-up in the Department of Hematology under AIIMS. Coming to the history of present pregnancy, that was an unplanned spontaneous conception. She had regular antenatal visits at a community hospital at Lucknow. She was on regular cyclosporin treatment, which was stopped once her UPT was positive. During her first trimester, she didn't have any history of epistaxis, mucosal bleeding, or dyspnea, or any other features suggestive of anemia. Her NT and dual marker, quadruple markers have not been evaluated. During her second and third trimester, she was on regular intake of iron and calcium, and she has received 2 injections of TT, and there were no features of anemia other than the current presentation. When she presented to us in emergency, she was admitted on evaluation. Petechiae was present all over the body, and she was evaluated, on which hemoglobin was found to be 4 grams. Her TLC was 9490, and her platelet count was 0. She had urgently received 4 PRBC and 6 RDP in emergency, and she was admitted under us. Her cyclosporin has been restarted, and during her hospital stay, her CBC was monitored, and she had required 2 PRBC and 6 RDP after admission. She was booked under our ANC, and a delayed anomaly scan was done at 30 weeks, which showed no GCA. And following which, she was discharged after a week, and she was readmitted with similar complaints of mucosal ulcers and oral bleeding at 32 weeks POG, and she remained admitted under us until delivery. Her menstrual history is as follows. Her previous cycles were regular. She had an average flow with no dysmenorrhea and clots. 4 years back, she had complaints of heavy menstrual bleeding, for which an evaluation was done and aplastic anemia was diagnosed, after which the complaints are relieved after 1 year of treatment. Her obstetric history, she was married for 8 years. Before the diagnosis of aplastic anemia, 6 years back, she had a full-term normal vaginal delivery at government hospital in Lucknow with a male child of 3 kg. She was diagnosed with aplastic anemia 2 years after this delivery, which was followed by a spontaneous conception in 2018, followed by MTP. It was done at 6 weeks of pregnancy. Past history is as follows. She had complaints of heavy menstrual bleeding with passes of clots in 2017, for which she was evaluated outside and found to have pancytopenia, very aplastic anemia. She has received 1 PRBC outside and was referred to AIIMS for further workup. And when bone marrow biopsy was done, aplastic anemia has been diagnosed, followed by which flow cytometry was done, showing a PNH clone of 12.8%. Over the past 3 years, she has received 47 blood transfusions for the same. She was started on danazol for PNH in 2019, but in view of deranged LFTs and jaundice, it was discontinued, following which she was on cyclosporin, which was discontinued once her UPT was positive, and we have restarted it at 30 weeks of gestation. On examination at the time of admission, pallor was seen, no icterus clubbing cyanosis lymphadenopathy was seen. Oral cavity has showed blood-stained gums with mucosal ulcers, and petechiae were present over the bilateral arms. Her systemic examination was unremarkable. On obstetric examination, petechiae were seen over the abdominal wall. Her uterus was 30 weeks of size with scephalic presentation, and auscultation fetal heart rate was at 140. Her antenatal investigations were normal. She was B positive. At the time of admission, her HB was 4 with platelets of 0. And on evaluation, her HCV was found to be reactive, and the viral load was high. It was 3 into 10% copies. Her other antenatal investigations are otherwise normal. So this patient had a multidisciplinary team approach for management, which included obstetricians, maternal fetal medicine specialists, hematologists, neonatologists, anesthesiologists, gastroenterologists, and transfusion medicine specialists. Her hospital course, she was admitted till delivery. A target of HB 8 grams and platelet of 10,000 was set, and multiple transfusions were given to the patient accordingly. Over a 6 weeks of antenatal stay, she has received a total of 8 PRBC, 34 RDP, and 1 SDP transfusion. Her cyclosporine was restarted at the dose of 100 mg in the morning and 50 mg in the evening. Dexamethasone was given to the patient at 33 weeks POG for fetal lung maturity. In view of high viral load of HCV, gastroenterology workup has been done. Ultrasound with splenoportal axis Doppler was done, which was normal, showing no signs of CLD, and fibroscan has a poor window. In view of no signs of CLD, no active intervention was done during the antenatal stay, and she was advised to follow postpartum for further management. This is the platelet trend and transfusion chart during her hospital stay. As we can see, most of the times her platelets was less than 10,000 only, and was maintained at that range with multiple transfusions. During induction of labor, just before her labor was planned, she was having a platelet of 28,000. She was planned for induction at near term. Before induction, we have arranged 2 SDPs for the patient. Her Bishop score was poor, it was 2. She was induced with dinoproston gel initially, 6 hours apart. 3 gels were given to the patient, but she failed to progress. A 24 hours therapeutic rest was given to the patient, following which mechanical method of induction was done with Foley's catheter and was aided by 1 more dose of dinoproston gel. Maternal fetal monitoring continued, and she progressed well to have an uneventful normal vaginal delivery on 31st. She delivered a female child of 2.3 kg with ABGA 9/9. Intrapartum, she has received 2 SDP, 4 RDP, and 2 PRBC. Postpartum period of the patient was uneventful. She didn't have any complaints of excessive bleeding from vaginally or any other site. Her postpartum CBC was 6.9 with TLC, HB of 6.9 with TLC of 9,000 and platelets of 20,000. 1 PRBC was given in the postnatal period. Her TLC was normal throughout. Prophylactically, oral antibiotics have been given for 5 days. Her dose of cyclosporine has been increased to 200 mg in the morning and 100 mg in the evening after hematological advice, and she was discharged on postpartum day 4 at HB of 7.6 and platelet of 20,000. Following up, her last platelet on this month was 14,000 with HB of 10 and TLC was normal. She now doesn't have any complaints of excessive bleeding, PV or bruising or mucosal ulcers. Her fibroscan and gastroenterology workup for HCV is pending. She was planned for contraception, LNG IUS at 6 weeks, and neonate is to be followed at 6 months for HCV evaluation. I invite my SR to come.
Good afternoon, everyone. This is the pictorial representation of how a aplastic marrow looks in contrast to the normal marrow. Aplastic anemia is a potentially life-threatening hematological disorder. It is characterized by absent or decreased hematopoietic precursors in the bone marrow, leading to pancytomania. Incidence is 4 to 6 cases per million in Asia and 2.2 cases per million in the West. Diagnosis can be established by bone marrow biopsy, which shows hypocellularity. Pregnancy with aplastic anemia is a rare entity, and it can be associated with high mortality rates up to 20%, and it can go up to the tune of 60% in cases of severe aplastic anemia. In 1888, Paul Ehrlich first described the first patient of aplastic anemia. She was a pregnant lady who died, and her autopsy showed fatty marrow with no hematopoiesis. The pictorial representation of normal hematopoiesis. Aplastic anemia results in depletion of stem cells and progenitor pool due to various causes like viruses, drugs, chemicals, radiation, congenital and immune mediated. The diagnostic criteria of aplastic anemia was given according to the Kemeta criteria, which was given in 1975, and it includes at least 2 of the following: a hemoglobin of less than 10 gram per deciliter, absolute neutrophil count of less than 1500, and a platelet count of less than 50,000. The severity of aplastic anemia was given by the modified Kemeta criteria, which was revised in 2016. According to this, severe aplastic anemia is characterized by both marrow cellularity, which should be less than 25% or 25 to 50% with less than 30% residual hematopoietic cells, or at least 2 of the following: an absolute neutrophil count of less than 500, a platelet count of less than 20,000, or a retic count of less than 20,000. Very severe aplastic anemia is characterized by severe aplastic anemia, same as severe aplastic anemia, but with an absolute neutrophil count of less than 200,
And non-severe aplastic anemia is characterized by aplastic anemia not fulfilling the criteria for severe or very severe aplastic anemia. The next entity is paroxysmal nocturnal hemoglobinuria. It is a non-malignant clonal expansion of the pluripotent hematopoietic stem cells. It is caused due to the acquired mutation of PIGA gene, which results in reduced or absent expression of GPI anchor proteins. It affects CD55 and CD59 cells in classical PNH, which can lead to hemolysis. Diagnosis is established by FLAIR cytometry. Worldwide incidence of PNH is 1.1 to 1.5 cases per million. PNH can be classified into classical PNH, aplastic anemia associated with PNH, which is the most common entity seen in 88% of the cases, and it can be associated with MDS in 3% cases. Classical PNH is further classified into hemolytic and thrombotic PNH depending on the clone size. Aplastic anemia and PNH consolation, as was seen in our patient, has a complex relationship. 30 to 40% patients of aplastic anemia have a PNH clone, but usually the clone size is less than 15%. Aplastic PNH can develop into classical hemolytic PNH, and conversely, classical PNH can also develop into aplastic anemia during disease progression. Both have a negative impact on pregnancy. The clinical features include various features of pancytopenia like easy fatigability, skin or mucosal hemorrhages, bleeding from the gums and epistaxis, low-grade fever or any infection. Usually no symptoms of classical PNH are present in these cases as clone size is small. Hemorrhagic or infectious symptoms may be seen in 50% of the cases. Time of presentation is usually in the second or third trimester as in our patient, but it can be as early as 6 weeks of gestation also. Complications mainly include maternal complications like spontaneous abortion in 6 to 16% cases, premature labor, preeclampsia, chorionitis, premature rupture of membranes, and gestational diabetes mellitus. Fetal complications can be seen up to 60% in 60% cases and include fetal growth restriction, IUD, stillbirths, neonatal death. Postpartum complications include postpartum hemorrhage and puerperal sepsis. Thrombosis at unusual sites like in liver and spleen can be seen if the PNH clone size is more than 50%. Other rare complications include chest infections, lung abscesses, panophthalmitis, fungal infections. Bleeding tendencies can be seen in the form of hematuria, hematochezia, macular hemorrhage, cerebral hemorrhage. Rarely, platelet refractoriness can also be noticed due to multiple transfusions. Uncomplicated pregnancy is seen in around 39.4% patients. Cause of mortality is mainly hemorrhage or sepsis. Treatment of aplastic anemia with PNH is mainly supportive in the form of repeated blood and platelet transfusions and a target of more than 8 gram per deciliter of hemoglobin and platelet count of more than or equal to 10,000 should be maintained in pregnancy. Prophylactic antibiotics or antifungals can be given if there is neutropenia. Specific therapy includes ATG, cyclosporin, and newer drugs like TPO receptor agonists, which are romiplastin and eltrombopag. Bone marrow transplantation is the most effective treatment, but it is contraindicated in pregnancy. Also, immunosuppressive drugs are teratogenic and embryocital to the fetus. Anti-thymocyte globulin and cyclosporin, current evidence does not favor routine use in pregnancy. It is used only in selected patients. In our patient also, it was initially stopped, but later on restarted at 30 weeks due to her current status. Timing of delivery. These patients can be successfully followed up till term with multiple blood transfusion, blood and blood product transfusion, immunosuppression, and antibiotics. Timing is usually based on severity of aplastic anemia and PNH and maternal and fetal complications. If aplastic anemia with PNH patients, they remain stable and there are no maternal fetal complications, they can be allowed to deliver till full term. If any obstetric complication is present, then according to the degree of that complication, we plan for early delivery. And if the aplastic anemia with PNH worsens, then delivery should be planned after fetal lung maturity. Mode of delivery, usually vaginal delivery is recommended. Cesarean delivery is only indicated for an obstetric indication. Induction should be planned near term. Platelet transfusion should be given 1 to 2 hours before delivery in case of cesarean delivery, and in active phase during normal delivery if the platelet count is less than 50,000. Review of literature. Because of concerns about fetal and maternal well-being, women with aplastic anemia with PNH are usually advised getting pregnant. As a result, literature regarding pregnancy complicated by AA-PNH is relatively sparse, and available literature may be biased by selective reporting. This was a study conducted by Stefania et al. In the year 2006, in which 43 case reports of PNH complicating pregnancy were reviewed. They noticed various antepartum and postpartum complications. Minor complications in the form of anemia, easy bruisability were seen in 74% patients in the antepartum period, and major complications like pulmonary embolism and Budd-Chiari syndrome were seen in 16.2% patients. Similarly, in the postpartum patients, minor complications were seen in 34.8% patients, and major complications were seen in 30.2% patients. 37.2% patients in this delivery had a preterm delivery, and 62.8% patients were taken till term. And vaginal delivery was seen in 60.5% patients, and cesarean section was done in 28% of patients. Fetal mortality was noted in 7% of the patients, and maternal mortality in 11.6% of the patients. This was the only study that we found comparing classical PNH with AA-PNH. In this, in the classical PNH subgroup, 16 pregnancies were studied in 9 patients. And in the aplastic anemia PNH group, 2 pregnancies were studied in 2 patients. In classical PNH, they gave eculizumab to 13 patients. And AA-PNH was managed with supportive therapy. Complications were noted in the form of Budd-Chiari syndrome in 2 patients in classical PNH. And in the aplastic PNH group, they had no complications. And pregnancy outcome in the classical PNH group was that 4 patients had stillbirth or spontaneous abortion, 1 patient underwent MTP due to Down syndrome, and the remaining 50% had preterm delivery. And in case of aplastic PNH, there was a favorable outcome in both pregnancies. Take home message: patients with aplastic anemia with PNH should be managed at a tertiary care hospital with multidisciplinary approach. Management is usually with blood and blood products transfusion and with immunosuppression. Target hemoglobin in pregnancy should be maintained around 8, and a platelet count should be maintained around 10,000. If the PNH clone is more than 50%, then antithrombotic therapy in the form of enoxaparin is indicated if platelet count is more than 20,000, and vaginal delivery is the preferred mode.
I think this is a case which is exemplifying a multidisciplinary team management, and I think I would like to invite people from hematology, particularly Dr. Mukul, who is here, to share his experience, and also transfusion medicine. Dr. Haim is here. So we'd want you to please give your comments and share, because this patient was essentially managed by their team.
Thank you, ma'am. At the outset, I'd like to say that aplastic anemia is not a very uncommon disease, but it's rarely managed in the hospitals elsewhere, including medical colleges. So we at AIIMS run a busy clinic on Fridays, weekly clinic, where we do see a lot of aplastic anemia patients, and it affects all the ages. So females of reproductive age are no exceptions, and a lot of some of these they do conceive. Although we do advise them for proper contraception. Uh, like in this case, the patient had conceived and stopped cyclosporin on her own, and came late in the near delivery, in near term, and was managed well. So the problem with aplastic anemia patient is during pregnancy is that most of the definitive therapy which is advised is a relative contraindication. The BMT is a relative contraindication. There's not much data of usage of antithymocyte globulin with it, and the only thing which can be given is a cyclosporin based therapy. We know that cyclosporin lead to responses in only around 30% of the patient without pregnancy. So if we expect a similar figure in this case, like in this case, so we are not expecting great responses with cyclosporin based therapy as well. And the last thing was a TPO receptor agonist. These are relatively new drugs which have come up in the for last around 6-7 years and are used in combination with immunosuppressive therapy and usually not used alone. And during pregnancy, these are relatively contraindicated as well. So you are left with practically not a great choice of drugs to treat, and cyclosporine can be given. So what you have is mainly blood transfusion support for these patients, which should be offered to all of these. Luckily, this patient didn't have a severe neutropenia. Otherwise, the course would have been further complicated by onset of infections and prophylactic antibiotics or even therapeutic antibiotics at times. We aim to maintain a hemoglobin of around 7 to 8. Patient may require almost a weekly 2 to 3 units of transfusions. Regarding platelet counts, this is a cause of worry. Reason being that these patients are kind of platelet refractory by the time they approach their term. So whatever amount of platelets you give, they are not going to lead to a rise in platelet counts. So we usually avoid giving platelet transfusions if the patients are not bleeding. But for the procedures, for other things like during delivery, supportive therapy with the SDPs and adequate support is required. If we look into the literature, we find that for a CSF examination, for a lumbar puncture, a platelet count of 50,000 is required. For let's say epidural anesthesia, platelet count of 70, 80,000 is required. But we should remember that the level of evidence for these is not very high. And there have been ample reports which say that CSF can be done at, especially in malignancy patients, CSF can be done at platelet count of 30,000 to 50,000 as well. However, should ideally be done under proper platelet transfusion cover, either with the RDPs or SDPs. Lastly, there is this entity called pregnancy-induced aplastic anemia, in which the pregnant female develops aplastic anemia during pregnancy. This last entity is a relatively rare entity, and to be managed with the immunosuppressive therapy and blood transfusion support. The only good thing is a good proportion of these patients, almost like 30 to 40% of these patients, have a spontaneous resolution after delivery. This is something which can occur with this if the aplastic anemia is triggered during pregnancy. I'd like to invite Dr. Haim for his. Uh, Not exactly. Reason being, cyclosporin per se is it's a toxic drug and it's associated with many complications by itself. So gestational diabetes, the sugar levels are deranged, then renal and hepatic dysfunction can occur, and it predisposes to a lot of hypertension. So preeclampsia and associated complication can also increase. That's why I said at the outset that we usually discourage these patients for pregnancy, and at least during the time till a definitive therapy is being given to them. Yes, sir.
The transfusion medicine people, and that's what we really wanted to highlight it. With 0 women was walking and was brought to the casualty.
Yes, sir. So less than 10 is everything is same. It be 0, 5, 8, 10, it's all same. They do occur. They do occur, but not in all patients.
So Dr. Mukul has already highlighted the role of blood product transfusion. I'd just like to clarify one thing, that platelet count of 0 does not mean 0 platelet. These equipments have a threshold below which, if the platelets are there, they'll label it as 0, less than 1 or less than 10. So there are platelets inside someone. Suppose a patient has 1 platelet count per microliter. So if we multiply by total blood volume, it will come to around 3 to 5 into 10 to the power 6 platelets in the blood. So that does not mean there are no platelets. There is hemostasis going on, but the patient is prone to bleed, as 7,000 per microliter platelet count is required to maintain to stop spontaneous hemorrhages. So suppose we have below 7,000, when I'm touching this also, some vessels are getting destroyed, so my platelets are maintaining that disruption caused by pressure. So if the count is below 7,000, we will bleed spontaneously. So that's why the 10,000 count, above, maintaining above 10,000 is important, because we have to prevent the spontaneous hemorrhage in these patients. They are prone for that, so we have to maintain above 10,000. So I would just like to highlight some of the points which we should consider. Like firstly, the etiology. In this case, we knew that the patient is having production deficit. Is not producing platelets, her bone marrow was not functioning. Before we start platelet transfusion, we should also consider other factors. Are there any additional things which will hamper or which will affect the platelet transfusion? So those can be platelet antibodies. This patient was heavily transfused. If you see, the patient was transfused some 47 or 48 units before she came to us. So she might have platelet antibodies or HLA antibodies. So before we simply jump on to that it is aplastic anemia, there is production deficit, we should always consider whether there are additional factors in the form of platelet antibodies or HLA antibodies. Apart from them, are there any non-immune factors like infection, certain antibiotics or certain medications which the patient is on, because that will change our target. So if there are no other factors, only production deficit is there, then we will only maintain 10,000. But suppose the patient would have infection, the patient would have some liver disorder or some other factors, then our target will increase to 15 or 20,000. So here the patient had hepatitis C also. I'm correct. Hepatitis C itself is associated with aplastic anemia. There are case reports and there are a number of reviews where they say that hepatitis C associated aplastic anemia is a quite common entity, and other hepatitis viruses are also associated. So it may be one of the causes for her aplastic condition. We don't know yet. So we should consider hepatitis C also as an additional factor, because it may cause liver disorder, which will reduce the thrombopoietin and the patient requirement will go up. So in this case, there were not many factors except hepatitis C, but thankfully her liver enzymes were normal. Only ALP was raised once or twice, so there was no need to be more worried about her other factors. Then when we transfused her with the platelets for first time, she maintained the platelet count for around 5 to 7 days. When we transfused at the zero platelet count, so that indicated that the platelet survival is normal. Ideally, full dose of platelet would survive for around 7 days, because uh, uh, every day around 1/7 to 1/10 of the platelets are getting destroyed and the same amount is getting produced. So if the patient is not producing platelets, every day 1/7 of the platelets will get destroyed. So if we have given a full adult dose, it will survive for at least 5 to 7 days, which happened in this patient. So there was no abnormal HLA antibodies or HPA antibodies. So we didn't have to consider about that point also. Now, coming to the plan, this was regarding the factors and what can cause, how do we assess whether the patient will require platelets or additional threshold. So the plan also included two different aspects. One was whether when the patient is going to deliver. So here the patient was with us for around 2 to 3 months. So during that time, we needed to maintain the platelet count above a threshold of 10,000 so that she does not bleed. The second was what to do when she is getting delivered. During the time of delivery, what should be our target? So at that point of time, for maintaining, we can simply give 2 platelets on every alternate day or 3 days, depending on how her platelet count is maintaining. But during delivery, RDPs are not a better product, because we cannot say that a specific amount of platelets will be inside those packs. So we need to arrange single donor products for such patients. And the single donor product should be targeted towards, as I think someone said, that towards the active labor if we are going for normal delivery, or 1 to 2 hours before the procedure is going to happen, or before we are going to make the make the cut in the patient. So SDPs are a better product during the time of any active intervention, because we need to maintain hemostasis and the platelets which are required will be very high. Another thing which we need to consider in such cases, especially in pregnancy, is what is going to happen to fetus. Since we assume that this patient does not have any antibodies, but we need to prepare for those contingencies also. There may be additional antibodies which are not causing destruction in the mother, but which may cause destruction in the fetus, because the fetus will have antigens from the father also. So we have to consider whether the fetus will be affected or not. I think ultrasound was normal in this patient, fetal ultrasound was normal in this patient, but still we need to keep some platelets, or we need to have some support for fetus also in these cases. I think which was arranged, but it was not utilized. 3 units were returned back to us because they were not utilized. So the platelet transfusion or even RBC transfusion we need to consider a number of factors as I described. So I hope this would be helpful for everyone in the future.
Before the case goes for comments and criticism, I would like to congratulate my colleague Dr. Vidushi because normally we all generally give up when we put in 1, 2, 4 cervicals here, but we stay put because we knew that the risk of cutting her would be far more and had to resort to using Foley's and mechanical dilatation until we were successful to have vaginal delivery. So I would just invite any comments and suggestions or any questions here. I think one question I have for Dr. Mukul, where does this woman go from here now? Because, here's an issue. Does she have vitamins? This her hepatitis C is also there. So does she go straight for a bone marrow or do we wait in for her hepatitis clarity and then, because it could be either ways.
Ma'am, if you look at her current reports, her hemoglobin is stabilized at around 10, and her WBC count is also normal, has been normal, and bleeding is also stopped. So for such a patient, I will not consider for a stem cell transplant upfront. I like to continue with immunosuppressive therapy, preferably ETD therapy now for her. Since she is already responding to cyclosporine, if there are paucity of funds or any other contraindication, I'll continue with cyclosporine.
We just thought we should be sent back to you and probably you'll be building her up for BMT. Thank you. Yeah.
She might have hepatitis C before she started transfusion, or the transfusion itself is the cause of hepatitis C. So now we cannot comment on whether the aplastic anemia is because of hepatitis C, although there are cases reported, even there are so many reviews which have said that transfusion may be the cause or hepatitis C itself can would be the main cause for this aplastic anemia.
Say about hepatitis individual, commonly due to non-B, non-A hepatitis. Uh, there are hinted that there are reports of hepatitis C associated with aplastic anemia. It is not the most common cause in hepatitis induced or the result.
Thank you.